Thank you very much. Thank you for the interesting talks by Professor Valni and Professor Odriozola. And I think this topic of my next talk is a very good presentation to follow all those other topics about autonomic neuropathy and different pain phenotypes. So I'm happy to present treatment approaches in diabetic neuropathy. So let's start with the peripheral diabetic neuropathy. So first of all, how do you treat a patient with symptomatic diabetic neuropathy? So unfortunately, every week patients come to me and tell me, yes, my family doctor told me I have diabetic neuropathy, but there's nothing you can do. It's not possible to treat it. Live with it. And I'm here to tell you that this is not the right answer to give to a patient, because there are several strategies we have or therapeutic tools that we can use to help those patients. First of all is the casual treatment, which means intensive glycemic control, reduction of risk factors, and exercise. Second, we have pathogenetically oriented treatment. And this means that we've, in the last 30 years, diabetic neuropathy was intensively studied, and there are the metabolism inside the nerves and the mechanisms leading to nerve damage or to microvascular diabetic complications have found many pathways, possible pathways. And pathogenetically oriented treatment means that we use the results or we use the suggested pathways to for new treatment strategies. So I will tell you about some substances for this kind of treatment. And last but not least, which is currently the most important kind of treatment, is symptomatic treatment. That means you don't alter the natural history, or you don't have disease-modifying therapy, but you have to do something against the symptoms of neuropathy. So let's start with the causal treatment. And first of all, you need to reduce cardiovascular risk factors. For example, treat arterial hypertension, tell the patient to stop smoking. I don't know if you will be successful, but it's important to remind the patient that smoking or alcohol intake should be reduced in diabetes. You need to correct worst glycemic control. So you need to take all the options you have to treat diabetes to have sufficient glycemic control. And there are other vascular risk factors you can reduce. For example, cholesterol or obesity. All those risk factors are modifiable. Other risk factors you cannot modify are increasing age or increasing diabetes duration, for example. In this slide, I show you a study by my boss, Professor Ziegler, that performed a study over 24 years, quarter of a century, with patients with type 1 diabetes. And the results were that in patients with type 1 diabetes with an A1C levels below 7%, you can see the rate of the incidence of neuropathy was significantly lower than in patients with A1C levels above 7%. So you can see that in patients with type 1 diabetes, good glycemic control is really important in the prevention and treatment of diabetic neuropathy. And I'm glad that a very important researcher and great person, Radhika Popusui, will talk later this day. And she performed really important studies in the USA from the DCCT and ADDICT trials that confirmed those findings, that in patients with type 1 diabetes, very good glycemic control helped to reduce the incidence of neuropathy. It may not be successful in all patients, to be honest, but I think it's very important to remind patients, especially with type 1 diabetes, to have good glycemic control. Unfortunately, there are not enough good studies that demonstrated such effects in patients with type 2 diabetes. Nevertheless, I would remind patients also with type 2 diabetes to improve glycemic control and risk factors, because the studies that examined the effects of glycemic control on measures of neuropathy were not originally designed to study endpoints of diabetic neuropathy. So I won't say it doesn't have an effect on diabetic neuropathy and type 2 diabetes, but the current evidence is not good enough to say, okay, if you have type 2 diabetes with great glycemic control, you can prevent neuropathy. So we cannot say that at the moment, but we have to keep in mind that the studies are not, that there are not enough studies that really focused on endpoints of neuropathy. For example, with small fiber structure from skin biopsies or CCM, or there were no studies about the irritable nociceptor, the gain of function phenotype Professor Odrinsola told us about. But nevertheless, you need to remind patients to have good glycemic control. Causal treatment also includes lifestyle modification. And as you may guess from this slide, I'm going to talk about exercise in diabetic neuropathy. And this is a topic that is quite controversial because it's not in the current guidelines and there are not enough studies, but I try to give you some hints in which directions the current evidence goes. So there are several studies available, but unfortunately, just a few of them are reasonably powered, good, or controlled. And my conclusion from those studies is that you need different types of physical activity for different patients. So, and you need to ask yourself, what is the goal in the treatment of diabetic neuropathy? If you really try to alter the natural history of diabetic neuropathy to cure the nerves or to prevent neuropathy, you would need very consequent exercise trainings over several years. So there are some studies that tell you about beneficial effects of exercise on measures of neuropathy like QST or nerve conduction studies over a few weeks, but all those studies are underpowered or are not controlled. But there was a study over 4 years from colleagues in Italy, and after 2 years of supervised training, they saw effects on nerve conduction studies. So if you, so that gives you an idea how difficult it is to improve nerve fiber function with exercise. But there are other effects of exercise too. So physical activity improves depression, improves quality of life, and also improves pain perception. So there are studies available that show that more physical activity does not initially improve nerve fiber function, but improves pain perception. So this is really important because pain perception can be modified, and this is important for against the chronification of neuropathic pain. So if you start early with physical activity, you have a lower risk to become a chronic pain patient. So, but I know how difficult it is to instruct your patients to do more physical activity. But maybe this presentation gives you a bit of information to provide to patients. And there's also training to not to improve pain perception or neuropathic deficits, but nevertheless improves quality of life. And this is balance training. There was a nice review about a German colleague of mine. They did a meta review of exercise training studies, and they found that balance training, or also there are some studies about Tai Chi exercise training, that they are effective to improve balance or against ataxia. And imagine for a patient with diabetic neuropathy who does not feel the feet anymore, it's very important to strengthen the muscles or to remain active or to remain a sense of balance. And I think balance training is a very good way to remain quality of life despite increasing nerve fiber loss or nerve fiber damage. So so far to causal treatment and lifestyle modification in patients with diabetic neuropathy. The next principle I talked about is the pathogenetically oriented treatment. And there are two substances I'd like to talk about, and both substances were mentioned by Professor Valli prior this day. And the first of it is alpha-lipoic acid. And alpha-lipoic acid is a substance that is very well studied during the last 25 years, I'd say. It can be applied orally by taking pills, or you can also apply it intravenously. It has a very good safety profile, and it has shown a good efficacy for treating not only neuropathic pain, but also for treating paresthesia like tingling or numbness. And for alpha-lipoic acid, there were many clinical trials performed, including the longest clinical trial for a diabetic neuropathy ever, the Nathan-1 study, over 4 years, and it has shown good efficacy against paresthesia. And I mentioned that because most of the other substances are tested for neuropathic pain, but neuropathic pain is not the same as symptomatic neuropathy. There are painful sensations, there are non-painful sensations that are also debilitating. Like tingling, so they cannot sleep anymore. And alpha-lipoic acid was tested also for treating paresthesia. And as we have heard previously, it's also efficient for treating autonomic neuropathy. The other substance is benfotiamine, which is sold as milligamma in most markets. And it is a pill patients can take once a day. And it's a derivative of vitamin B1. So vitamin B1 is a water-soluble vitamin, and milligamma is a modified form that is fat-soluble in the body. So the body can metabolize it more efficiently. Benfotiamine has a very good safety profile too, and there are several short-term studies that demonstrated beneficial effects on matters of neuropathy, not only diabetic neuropathy, but primarily on neuropathies due to vitamin B1 deficiency, for example, after alcohol abuse. But currently there is a clinical trial that we conduct in Germany with benfotiamine over 1 year to see how the effects are, or in which patients benefit most of treatment with benfotiamine, which phenotypes, which kind of symptoms are alleviated most by taking benfotiamine. So this is a very interesting field of study. And those treatments are, I don't know how the situation is in Romania, but in most markets they are over-the-counter drugs, so patients can buy them, but healthcare does not pay for them. But nevertheless, they are a reasonable approach. So I personally, if I had diabetic neuropathy, I would take them, but you will never know how the effect is. So if you take alpha-lipoic acid or milligamma for several years, you won't know how your nerves would be without taking it. But as I mentioned, with alpha-lipoic acid, there are studies available that show beneficial effects in patients who took it versus patients who took placebo. Next, let's talk about symptomatic treatment. And in this presentation, I'd like to give you specific information about the most useful drugs for symptomatic treatment of painful diabetic neuropathy. So those substances are tested again in patients with neuropathic pain, but they are also commonly used in patients without pain, but with paresthesia, like tingling. So the first substance is duloxetine, which belongs to the antidepressants. and it has a good efficacy. It works well against neuropathic pain, and one advantage is that most of the patients do not gain weight using or taking duloxetine. But the side effects include nausea and dizziness. So people, some people report that they don't feel well, or they feel vertigo, or they don't feel awake. But you really need to try it for several weeks after starting with a low dose to see how effective it is. The contraindications are liver damage and renal insufficiency, which is a disadvantage, but in patients with only slight elevated liver enzymes or with only discrete renal insufficiency, it's fine to use it. The next substance with a good efficacy is amitriptyline, which is a classic tricyclic antidepressant. It works quite well. It works also against depression. Both duloxetine and amitriptyline are used to treat depression, and depression is a very frequent comorbidity of painful diabetic neuropathy. So those substances, often you can catch two birds with one stone if you use an antidepressant to treat depression as well as neuropathic pain. But the disadvantage of amitriptyline is that it has many side effects, and you cannot use it in people with progressive heart diseases. The next class are alpha to delta ligands, and those are substances that are used to treat epilepsy. Pregabalin and gabapentin are very similar, but pregabalin has a bit more favorable pharmacokinetics, so it has more linear dose dependency in the body. So I usually prefer pregabalin over gabapentin, but I also have patients who prefer gabapentin over pregabalin. So it is worth to try both. Has a very good efficacy. And it can be used in patients with renal insufficiency. So you can check for the creatinine clearance of the kidneys and dose pregabalin or gabapentin accordingly. And also you need to start with low doses and hope that people do not experience side effects like dizziness or headaches, drowsiness, weight gain. But all those side effects I'd like to highlight are not dangerous. So it's not dangerous to try pregabalin and gabapentin when patients experience some side effects that are not related to renal function. It is safe to use, and patients can try to use it some more days to see whether side effects will vanish. Here I did a literature research with the recent Cochrane reviews about the efficacy of gabapentin, pregabalin, and duloxetine. And I think it's quite interesting if you have a look at the number needed to treat. How many patients do you need to treat with a substance to have a significant pain reduction of at least 30%? And if you look here, you have pregabalin 300 milligrams a day, which is quite a good dosage. It's a quite high dosage. You need 22 patients to have a significant effect. So that's not that good, but you can also increase the dose up to 600 milligrams a day. And the patients you need to treat are around half of that with the lower dose. So you really need to increase the dose far enough if the analgesic effect is not high enough. And you can see that duloxetine has the most favorable profile when it comes to pain reduction and number needed to treat. So duloxetine is worth a try if patients have good enough renal and liver function. The second line therapy for painful diabetic neuropathy includes opioids, and you can start with weak opioids and strong opioids. You can also try combination therapy. You can try to combine pregabalin and duloxetine, for example, and you can also try combine duloxetine with opioids, for example. And there's quite a debate whether you should prefer monotherapy or combination therapy. But in my opinion, you can try combination therapy if you tried the highest possible dose of one substance. The advantages of opioids are good efficacy against pain, especially against pain that is influenced not only by diabetic neuropathy, but also by, for example, slipped discs or spinal canal stenosis. So there are many patients that have diabetic neuropathy and also arthritis or arthrosis or nerve compression syndromes, and opioids are in many cases the best options those patients have. But you should really be careful to prescribe them because there's a great risk of addiction and abuse. And maybe you've heard about the opioid crisis in the USA, and we don't need another opioid crisis in Europe. Now let's talk about some other options we have, and maybe you're wondering why I show you this chili peppers on the screen. So I show you those because chili peppers or hot chili peppers contain capsaicin, which is the substance that you feel as burning in your mouth when you eat hot chili peppers, and that substance you can use to treat painful areas with diabetic neuropathy. So that sounds strange, but how does it work? It works like that capsaicin reduces the nerve fibers in the skin. So what you do with this is you provoke artificial nerve fiber loss in the upper areas of the skin. So you perform a denervation within the skin. And that sounds a bit strange, but in some patients it works. In my experience, it's a useful treatment option in patients with evoked pain. So with pain that patients feel, or like allodynia. So you touch the skin and the normal touch sensation is painful for those patients. And I use it especially in those patients because it kind of kills those maladaptive nerve fibers in the upper layers of the skin. But there are no studies that examine whether capsaicin increases the risk of diabetic foot ulcers, because if you have less nerve fibers in the skin, the risk for foot ulcers increases. So it is more safe to use it in parts of the foot that are not on the plantar aspect of the foot, in my opinion. That may be not scientifically studied in clinical trials, but you should keep that in mind. But it's a useful tool. You can use it in patients with renal insufficiency, with many other concomitant diseases, and it's easy to apply, but it needs to be done by a physician or assistants. So how does it work? Patients tell you about the most painful areas, and we apply the capsaicin patch. So we cut it to the right size, and we apply it for 30 to 60 minutes, depending on the patient, and it has to be repeated every 2 to 3 months. And it is worth a try. Some people benefit from it, others do not. But as I have shown you with the Cochrane reviews, also the other symptomatic treatments are trial and error approaches in painful diabetic neuropathy. So if everything that I told you previously did not have a significant effect on neuropathic pain, there are other treatment approaches that are non-pharmacological, so without drugs or active substances. One of them is the transcutaneous electrical nerve stimulation that may may alleviate pain in some patients, and it's also a licensed tool to treat diabetic neuropathy, but in my opinion, it does not help a lot of people. So you can try it, but I don't have much experience with it, and most of it was negative. So maybe patients liked to feel the electrical sensation or the muscles working, but the effect on neuropathic pain is limited, I'd say. In patients with chronic pain and dependent on opioids and with limited treatment effect, even of combination therapy on opioids, there is a quite new technique to implant a spinal cord stimulator, which is done by neurosurgeons. And what they do is that they implant the electrode in the spine to stimulate the nerve roots, and the patients get a device to choose different programs or different stimulation patterns. And this is, I'd say, it's a useful tool, and patients can benefit by it, but it's should be limited to very severe cases that cannot be treated otherwise. So you need to have tried all other treatment approaches before you send the patient to a neurosurgeon to have a spinal cord stimulator implanted. Okay, so let's sum it up that the treatment of painful diabetic neuropathy is primarily symptomatic. So you can tell patients about causal treatment and pathogenetically oriented treatment, but in reality, the most important treatment strategy is still primarily symptomatic, unfortunately. The role of analgesic treatment is not only to alleviate pain, but also to improve the quality of sleep and quality of life, to help the patients to participate actively in his or her social life and work life. Because the problem of pain is not only the pain sensation, but also everything that comes with it. The whole life can be disrupted by chronic pain. So the symptomatic treatment should be initiated early to avoid chronification of pain and all the sequelae. And last but not least, regular painkillers that patients often take against headaches or stomach ache, etc., are not useful to treat neuropathic pain. So please avoid to prescribe ibuprofen or naproxen or paracetamol in those patients. It does not work in the good case. It does not work. In the worst case, it damages liver or kidney. So it's not useful to use that or to recommend that. And let me remind you again that concomitant diseases have to be considered to choose the right treatment. So if I told you that many patients with diabetic neuropathy suffer from depression, so those may benefit from antidepressants. You need to start with low doses and subsequently increase it until you have sufficient effect, or the maximum dose has been reached, or side effects occur that the patient cannot tolerate. And one piece of advice from the clinical practice, I see often patients with pregabalin 75 milligrams per day. That's not enough, and gabapentin 300 milligrams is also not enough. So in most cases, you can increase the dosage of those substances. Some few points, I'm running out of time, but a bit of information about the treatment of cardiovascular autonomic neuropathy. Also, you have also causal treatment with reduction of risk factors and intensified glycemic control. You have the modulation of the heart rate variability, which you can reach by choosing the right substances to treat other diseases, and you can treat the complications of cardiovascular autonomic neuropathy, like orthostatic hypotension. There are recent studies that causal treatment or intensive diabetes therapy helps not only patients with type 1, but also in type 2 diabetes. There's recent evidence available, and you have less development or progression of autonomic neuropathy when you reduce risk factors. There are some substances that should be avoided if possible, which are certain beta blockers with intrinsic sympathomimetic activity. Unfortunately, several antidepressants have a worse effect on heart rate variability, but there are also substances that you should prefer. And in my experience, ACE inhibitors or AT1 blockers have a good impact on heart rate variability. So, and they have a good safety profile and are beneficial in many patients. So I would suggest you those substances. Also, digoxin and verapamil and other beta blockers like metoprolol are useful to increase heart rate variability. One piece of advice for patients with orthostatic hypotension. So those patients need to be instructed to do physical maneuvers before they stand up, for example. They can increase their muscle tensing, or they can cross their legs, or they can do the hand grip, and that increases the circulation and increases this ameliorates the symptoms of orthostatic hypotension. And there are other drugs that are too complicated to remember now, but you know where you can look at those in those cases. And with this, I'd like to end right on time. And thank you very much. And I'm happy to have your questions. Thank you very much.